You are listening to the
World Extreme Medicine.
The World Extreme Medicine
podcast.
In this session, we're going to be speaking with Daniel Grace on the Livingstone Revisited 2024 expedition. So what I wanted to do in the episode is really dive into the transformative journey of the Livingstone Revisited expedition. So this remarkable expedition retraces the historic path of the Scottish missionary David Livingstone, but with a modern twist. So the expedition spans over 2,000 kilometers through Zambia's diverse landscapes, from savannas to swamps to national parks. So the expedition aims to revolutionize healthcare accessibility in some of Zambia's most underserved communities. So utilizing cutting-edge telemedicine technology, virtual doctors are establishing new clinics and indeed connecting patients directly with healthcare specialists. So the expedition also aims to address critical issues of power outages by distributing solar lanterns and chargers, ensuring clinics can provide uninterrupted care. So if that wasn't all enough, the expedition is also partnering with Snake Safety Zambia, which is also implementing life-saving pre-hospital snakebite training programs, which empowers local healthcare providers with essential skills in snakebite training. So in the podcast, we're going to dig into all these topics and explore the efforts with Daniel Grace, who is no stranger to the podcast. Welcome, Daniel, to the podcast.
Thanks, Owen. Yeah, good to see you again. But yeah, I am the medical director of the charity, and the charity is linked, weaved into the expedition. But as you say, we've got a few other stakeholders, Snake Safety Zambia, Solite, who are helping us out with the solar lantern. So yeah, it's really exciting. Loads of moving parts, as there is with any expedition such as this. But yeah, really pleased to be able to talk to you about it.
I just wonder if we could start, Daniel, really just if you could just give us maybe a brief overview, if that's okay, of the Livingstone Revisited expedition and indeed its main objectives.
Yeah, sure. So I suppose if we rewind back to probably the latter parts of the pandemic, it was a case of myself and Hugh Jones, who set the charity up, having sort of our weekly meetings. Obviously, COVID hitting places which had a sort of, well, they were very low resource compared to a lot of the places we were working in and things. And that was always a conversation about global health and trying to work out how to help and things. And as we came out of the pandemic, I suppose like everyone, we were sort of thinking, okay, it would be nice to travel and sort of to visit Zambia, because Hugh used to be a safari guide out in Zambia back in the 80s and the 90s. I'm a medical director of the virtual doctors, and we were conscious that there are loads of health challenges within Zambia, which is where we're predominantly working. And we just wanted to it started off purely being an idea of getting an up-to-date feel of the challenges on the ground. And of course, you can get that through talking to people remotely, through Zoom or otherwise. But we wanted to sort of look into that. And so that's purely where it started. So something very simple. But then as we started talking, we thought, okay, there's actually quite a number of clinics we support. So there's over 300 in pretty much all the districts of Zambia. And we started looking at maps, discussing different things. And as we were doing that, and Hugh is very much into his history and his geography and all that sort of thing. As we were doing that, we were like, some of this traces some of David Livingstone's expeditions. That could be an interesting link. And I was sort of like, oh yeah, that does sound cool. Also conscious that we didn't just want to go on sort of a holiday through Zambia. Whilst that would be really nice, it doesn't quite fit with what we were trying to do. So, but that's where that Livingstone idea came from, if you like. And as we were looking at those routes, there were certain parts of not a specific expedition, because Livingstone did all sorts of different traveling, but there were certain bits. So where there's a memorial in Zambia where he died, and there's also Livingstone, the town, and various other places. So there was that link, and as we sort of thought about our journey, we sort of got the theme that David Livingstone, so for people who don't know about him, he's famous, for that Dr. Livingstone, I presume, when Stanley, found him after a few years of him being relatively off grid. But his background, so he was born up in Glasgow and Blantyre. There's now a museum at the site of where he grew up and things. But so he trained to be a missionary. And the expedition it's a secular expedition. It's not religious. However, we quite liked the idea of, he was a missionary, spreading religion at the time. And we are sort of through the telemedicine charity aspect, which we can talk about in a little bit. We quite like the idea of us being digital missionaries. So spreading connectivity, so spreading the ability for a patient to then go and see a rural clinician, and then that clinician is able to connect with volunteer doctors in the UK to get healthcare advice. And the long-term aim is that they connect with Zambian doctors to get that advice, and that within Zambia, then the system, the technology system works. At the moment, per capita, that's not really feasible just because there aren't enough doctors. But the idea of digital missionary sort of spread from that. And you can see that then the expedition started to get a bit of an identity. And then sort of organically, that then through discussions with Scott Johnson, actually, he's certainly been involved with WEM up in the conference a few years ago. Me and him did a panel on disruptive technology and other things. But he's very much involved in, firstly, telemedicine, but also solar energy, solar lanterns, charging, lots of sort of innovative solutions that look at the sustainable way that we can do things. And then that sort of naturally evolved into this idea of spreading light and providing these solar lanterns to the clinics that we're going to go to. And the relevance behind that, we can unpick that in a bit more detail a bit later maybe, but Zambia, like many countries in sub-Saharan Africa, is having huge issues with drought, power outages, and like enforced power rationing. Which obviously, if you're trying to do anything, but particularly run a healthcare facility, that comes with its challenges. So that, I suppose, those are sort of some of the key aspects of the identity and how it evolved. And then we thought, okay, this is all very good, but we want to have some more sustainable outcomes as well. So we can do some, obviously having a telemedical app is good in itself to sort of educate and things like that. But if we can do some face-to-face training, if we're there in the country, then that's a good thing. So we picked pre-hospital trauma and snakebite as our two priorities, if you like, and that's based on the information that we've got lots of data from cases that have been sent, and we know that there's a huge burden of morbidity and mortality from trauma and also snake bites. And I'm not saying that this expedition is going to address all of that, but the idea is that we'll be running some bespoke training and then essentially cascading it down to a trainer sort of model, and then sort of following that up. And the snake side of things, we're hoping to develop some guidelines, do some pilots with the Ministry of Health, and then roll that out through probably first off a district within Zambia, but then hopefully get enough traction to then spread that throughout the country. So a few different strands. That's quite a long answer to your first question, but yeah.
No, absolutely. But to your point, Daniel, it seems to have kind of grown quite organically. And I guess that really is the basis of my second question, really, sort of what it means to you personally, because it does seem to have almost grown legs in different ways and has got different endpoints and different objectives. But so fundamentally, what does it mean to you? It sounds fantastic in multiple streams. What are you fundamentally passionate about?
Yeah, that's a good question. And you're certainly right in that it's morphed and changed so many different ways since we had these first discussions of probably a few years ago, and then the main planning has been sort of 8-9 months or something, and it's now got its identity and it's set because we're going in sort of in a month and a bit. But yeah, I think if you look at all of the themes that kind of underlie all of those things I was just saying about, for me, it's the global health aspect of it. And I know that might sound a bit cliched, but I think what I noticed a lot during the pandemic was that globally, everyone kind of became aware that actually there are a lot of health issues that we probably just don't think about a lot of the time. And I think the pandemic opened everyone's eyes to that a little bit. And maybe the cynical part of me says that everyone's maybe not completely forgotten about that, but it's certainly taken a bit of a backseat, which I understand. So for me, one of the things is just to get people talking about some of the health disparities. And one of, going back to the Livingstone thing, so Livingstone did loads of expeditions and things, got super unwell during most of them actually, and ended up succumbing to sort of severe malaria and internal bleeding and things like that. But one of the things, if you think that was back in the Victorian times, so we're quite interested in saying, okay, look how medicine has changed. At least in a lot of places, it's changed. Access to healthcare has changed. In some countries, actually, access to healthcare, of course, it's advanced compared to then, but there are still loads of challenges. And how can we sort of start that dialogue about things? And the other thing is actually looking at, disease demographics. Malaria is, it's still a massive issue. I mean, snakebite, one of the main neglected tropical diseases that the WHO wants combating. And then things like this, and without getting sort of super political and talking about the way sort of pharma works and funding and things, there's a whole bunch of neglected tropical diseases that maybe don't get the funding and the research that they need, but they still affect a huge number of people. So for me, I think the main thing is raising the awareness of that lived experience for people who are, still experiencing and suffering with some of these things. Also raising the profile of the charity and the other stakeholders involved. So that then hopefully the expedition, yes, it achieves its short-term aims, then it has those sustainable strands that we were talking about, but also it acts as a vehicle, so hopefully producing a documentary out of it. So then we have something concrete that we can show people, and then they watch it and think, oh, actually, yeah, that is kind of an issue. Maybe we should do something about it. So I suppose those are the main reasons that I want it to succeed, at least.
Well, I mean, one of the core concepts of virtual doctors really, and this kind of notions towards my third question, is really accessibility to healthcare, indeed remote healthcare, and
Yeah.
indeed reach back to telemedicine initiatives, just improving accessibility fundamentally. But could you speak to how you're going to look to achieve that in a sustainable way so that there is sort of almost enduring sustainability over time?
Yeah, I think that's a really good question. And if we rewind back to, I'll just say a bit about the origins of the chat actually, because that kind of links to the sustainability. Because we get a lot of people asking us about virtual doctors. How can people set up a similar service maybe in another country and things. So it all stems back to when Hugh, as I say, was working as a safari guide out in Zambia, witnessed a lot of potentially preventable death and disease, essentially. He's not medical, he is not technological either. And so you might think, well, what was he doing? So setting up this charity. But if we fast forward to now, so that we have this smartphone app that goes out to clinical officers, equips them at these rural health centres. All the in-between stuff comes down to memorandums of understanding with the Ministry of Health, discussion with stakeholders on the ground, setting up a board, both in the UK, but also in Zambia. So it's always been a Zambian organisation, a Zambian solution. Yes, there are elements of involvement from the UK, purely because per capita, the number of, so I know it's hard getting GP appointments in the UK, but the stats, it's about 1 to 300 in terms of, doctors to people. Whereas in Zambia, it's 1 to 12,000, which is crazy when you think about it. And that's why it ends up being like in a lot of countries, you'll have clinical officers, so people who've done a year or two's basic training, and they then get sent out to these areas. They've got a huge amount of skills, don't get me wrong, but sometimes, like all of us, they want a bit of advice. And the idea of equipping them with telemedicine was one of the ideas to combat that. Longer term, and actually this is quite relevant because our technology is always a challenge. It's expensive to get good technology, and historically all our coding in our app was done by volunteers, which was really awesome of them. But it was a bit like if you imagine a Lego model and then the functionality needs to be added, so you just put some more blocks on it until it's a really crazy Lego model, and you want to change something in the middle, to make it work more efficiently or to meet the demands of other stakeholders. And the only way you could do that was throw it against a wall and completely smash it. So that might sound a bit odd, but what we've had to do is completely rehash our technology. In fact, we were lucky enough to get some funding, and we've developed that for the last 18 months or so, and that went live 2 weeks ago. But the significance of that is that it now has a system in place. So if a clinical officer wants to ask a question about, I don't know, an unwell child or something like that, initially it will then go to a local Zambian clinician, then a slightly less local Zambian clinician. And then if no one answers, it goes to the UK. And we have the ability to flex and change that, depend on, availability, demand, and things like that. Because the whole idea is that as a charity, at least within Zambia, we put ourselves out of business. we hand over the tech and the setup, hoping that logistically that helps, because it's all been sort of designed in conjunction with asking clinical officers and district health officers what actually works for you. We can still stay as a little backstop, just in case there aren't anyone available to answer cases. But then we pull out and we go to another country, and Malawi's the next one. We're sort of doing some pilots there. So the sustainability and having an exit plan, I think, is really important. Otherwise, there is that risk of, I guess you call it healthcare colonialism or something like that. And that's always something that we've been aware of in terms of, the optics and how that can look as well. And that actually brings us, interestingly, full circle to Livingstone, because some people have said, well, how does that look in terms of calling an expedition that? Which is interesting. And it comes back to, sure, let's have a dialogue about that, because that's, something to think about. But interestingly, I think Livingstone, he's actually held in good regard in Zambia and Malawi. He was very much against sort of abolishing the slave trade and things. But the flip side of that is, yes, some of his exploration were potentially seen as opening the doors for like the scramble for Africa and things. So it's not without potential controversies and things. And as a charity that's retracing and looking into some of that, how does that look? I think it comes back to, well, if it generates discussion about some of these topics and some of these neglected issues and diseases, then that, for me, that's a good thing, at least.
Listen, I would absolutely agree, actually, and like you said, readdressing the narrative with these outcomes and these main objectives, which are, like you say, wholly good but sustainable. And I think it's fantastic, as you said, to have an exit plan, but also to have proof of concept. So lessons learned from Zambia, like you say, you can extrapolate through to different countries in Africa and iterate and improve as you go. And I think sustainability is such a fundamental aspect of it, and I think that's really, just through the adage of time now, just looking at the next question around just really around the solar connectivity, and because sustainability is a fundamental part of your strategy within solar connectivity as well. And I guess my question is, could you speak to the solar lanterns and indeed chargers and how the sustainability piece fits in there together with healthcare services?
Yeah, so the solar side of things it's really interesting. Well, it's quite tragic at the same time. I mean, so initially that just started off as a discussion with me and Scott Johnson. So he was saying, it might be interesting to come along, get some ideas about, the demand, the need for solar energy and things like that. And then I suppose in parallel with that, there've been issues with, dry weather spells, droughts and things, but it's been particularly bad in Zambia this year. So there's been a drought. It's affected almost 10 million people. So that's almost half the country's population. And the El Nino weather system has made that a bit worse, but it's destroyed a huge amount of maize crops. So there's issues with, hunger, famine, things like that. The other issue, though, is because of climate change and that dryness, the main lake called Lake Kariba, which is in the southern part of Zambia, essentially on the border with Zimbabwe. So that is at 13% of 1/3 of what it should be in terms of its levels. And that essentially has a dam at each end, one that's responsible for most of Zambia's power and one that's responsible for most of Zimbabwe's power. So they have a huge deficit. I think it's projected that drought has a deficit of about 430 megawatts. And if you're like me and you don't really know what that means, 1 megawatt can power 2 fridges for a year, or it's sort of 3,000, 4,000 miles on sort of like a Tesla or something like that. So, long and short of it, there is an issue with power. And because of that, houses, businesses, everyone basically is having to ration their power, mandatory power outages, sort of 12 hours a day and things. So obviously that is not ideal if you're trying to do anything, but particularly seeing patients. And the idea of, clinics are supposed to be places of safety. People are going to be less likely to go there if it's not light from purely from a safety perspective of getting there. But even that, if you want to examine a patient and you don't really have a good light source, then that's tricky. And also, we're talking about a telemedical service. you need technology, you need a handset at least to be able to send some cases. So being able to charge things using solar is really important. And so, yeah, with Scott Johnson, so he's involved with a company called Solite, along with a lady called Alice Chun, who sort of founded the company. They've done a whole bunch of humanitarian work, sort of supplying lanterns to hospitals in Ukraine and elsewhere following other disasters and things. They're super cool devices. They sort of fold up flat, ultra portable, and yet you unfold them and charge them and then use them. They can supply a lot of light. So that sustainable aspect is really important. And it's sad that it's become a more relevant part of the expedition in some ways. And because of if you look at and this is interestingly, there's links to a quote from the Ministry of Environment in Zambia. But basically the theme is, look, Africa hasn't really contributed to climate change. If you look at the emissions and where they're coming from, Africa's not really done very much. But actually the consequences are hugely severe, and these massive droughts and things. So again, it's good that we're looking at solutions, but I guess, it's all very well trying to find these solutions, but you need to kind of address the, things upstream. But without getting too cynical on climate change and things. So that's a significant issue with the solar power. But we're hoping to at least be able to, address that in the clinics we support and empower people to at least better get safe access to healthcare.
Could we just pivot and just look for a minute at the snake safety Zambia collaboration? Could you maybe speak to what prompted the collaboration, Daniel? Also, and indeed, how the snake bite training programs are going to benefit the local communities?
Yeah, so the nice thing about having been embedded with the Ministry of Health and running the virtual doctors for, I suppose, over a decade now, but we've had good data at least since about 2016 and things, means that we can look at the burden of disease and the kind of cases that we get. And we get quite a lot of snake bite cases that come through, both the kind of the acute management, but also, longer term disability they can get as a result of that. And I suppose it's important to point out here that what we're doing through the telemedicine, it's not an emergency service purely because logistically that doesn't work. So the idea is that, if someone's been bitten by a snake, that immediate management needs to happen, and the case can be discussed with someone sort of as a more of an educational side of things. But the issue with snake bite is like we were saying, it's a neglected tropical disease. I think if you look at the stats, there's sort of around 140,000 deaths globally. That's worldwide, not within Africa, and almost 500,000 sort of permanent disabilities and things. So it's a significant issue. This links a bit with the Solite project. So prevention and having good lighting is obviously one of the most important things. But looking at the training, so first off, for clinical officers, it's not that they don't know about snakes. I just want to clarify that it's not like that we're going and saying, hang on, we know everything, you don't know anything, let's go and give you some training, because that comes back to what we were saying before, completely inappropriate. But even with, and wherever you go, there's always myths within how you're meant to manage snake bites, whether it's tourniquets, historically sucking things, cutting, all sorts of different things. And if you add into that potentially different health beliefs of traditional medicine, herbal medicine, and things like that, it's a discussion point. And what the training is aiming to do is, part of it is peer learning, what people are actually doing. That's one of the things we actually want to find out about. Like we were saying, this is more of a pilot to identify the main challenges and then work out some solutions. But we've reached out to Snake Safety Zambia. So this is an organization set up by a guy called Marcel. He's actually from Holland initially, but he's lived out in Zambia, and he's been working with the Ministry of Health to develop snake bite guidelines. And most of this comes down to the basics. So similar to the stuff we teach on World History Medicine courses, the safety, doing a good primary survey, but specifically for snakes, looking at the patient and working out which toxidrome they're most likely to be having or going into, and then looking at how the management is potentially different based on what's going on. So whether that's more of a neurotoxic thing and they're going to need a bag valve mask, respiratory support, whether it's more sort of necrosis, local tissue damage, a combination. But what we want to do is, and the sustainable aspect of this is developing a pro forma that then looks at, okay, this patient has come in with this presentation. We think it's that kind of snake. We want to then understand the thought process that the clinician goes through to then be able to evaluate, has the training helped? We're obviously hoping that it will have helped. And then we can say, okay, this has worked as a pilot, and then we extrapolate that out. There's always that discussion about antivenom as well. It's always interesting to talk about, but pragmatically, and again, this is something that we're going to investigate more whilst we're there, because getting information face to face is so much easier than sort of through online surveys and things like that. But one of the main issues is obviously supply chain in terms of being able to get antivenom, cold chain as well, and also being able to give it in a facility where it's appropriate next to the risk of anaphylaxis and things. So there's a whole range of different topics we're trying to discuss there and sort of think about. But yeah, the main reason is a mixture of that disease burden, those statistics, but also looking at really trying to get the Ministry of Health on board. It comes back to what we were saying at the start, we're not just going to just do what we want. And the same with the virtual doctors. You always have to have buy-in from, the local government essentially and stakeholders, because otherwise it's not the right sort of thing to do. But yeah, it should be really good. And the idea for the snake perspective, this is very much a pilot that we're then going to roll out long after the expedition's gone, really, so that we can then cascade it out. And I don't need to be there for that. But at least we can get those logistics and things sorted out whilst we're there.
Well, something you just said there, Daniel, which is absolutely key, actually, and is reproducible and is fundamental in a lot of ways, is this bi-directional knowledge sharing, actually. So it's, as you said before, it's actually, inferring knowledge and understanding from your perspective, but it's also listening and active listening as to how local services deal with snake bites, and indeed with a lot of issues, actually. And actually, what would be really interesting about this expedition is the post expedition report and analysis, because sharing that with the Ministry of Health within Zambia is super interesting, because as you said before, you'll probably learn as much as you give, which is this symbiotic bi-directional learning, which is absolutely key to, like you said, not coming in thinking that you know it all, but actually learning from locals as well, which is fundamental. Could you speak to that a bit more?
Yeah, I think that's so important, isn't it? I mean, it harks back to the whole sort of origins of how the charity started working as well, in that originally it was all set up, and so this was long before I was involved. This is when Hugh was sort of trying to set it up, and it was with off-the-shelf telemedicine software, trying satellite phones, all sorts of every bit of technology. I think at one point they had like Windows computers, but there wasn't enough power, so they just sat there not being used. And and that wasn't through anyone's particular fault. Mobile phone technology wasn't what it was. It wasn't what it is now. So the key thing there is, though, that actually the way that we got functional solutions was by listening to the clinicians in Zambia. It goes back to what I was saying about it being very much being a Zambian solution, but with a UK arm to help support it. I think that's probably the most, and that's the thing with the expedition as well. That's why I've been so careful all the way through to get partners involved who are either based in Zambia or they have an understanding of the challenges there, because otherwise it just doesn't work as a concept, I don't think.
Yeah, absolutely. And I think it's powerful in a number of reasons. You could just pivot slightly and look at sponsorship and support. There are some fantastic endpoints and initiatives to this expedition. How can businesses and indeed individuals get involved in supporting the expedition?
Yeah. So for people who want to get involved, we've got a Just Giving page. So our website is livingstonerevisited.com, which we're actually about to refresh it into a new website, one that's been built by someone with better web skills than me. So that will hopefully be going live start of next week. But even at the moment, it's got a link to our Just Giving, so people can contribute that way. That would be massively appreciated. And yeah, if businesses want to get involved, we have a page on sort of sponsorship tiers and things. But yeah, any support is always greatly received. And yeah, we have ways of sort of what's the word, rewarding you for your involvement, if you like.
No, indeed,
Yeah,
indeed.
it's all about people who share that. Anyone who shares that vision really, or that experience of working in a low resource setting with those health challenges. Most of the people who've become sponsors or got involved is because they identify with, that whole idea of what we're trying to do, I guess.
I think what we'll do as well is we'll put links in the show notes so people can find out more quite easily about the expedition. And
So
just
that'd be cool,
looking,
yeah.
yeah, absolutely, absolutely. Just as we're coming to land, a few more questions, really, Daniel. One would be, there is quite a significant logistical burden to this, or burden, but a logistical element to this expedition. It's 2,000-kilometer journey through Zambia. Could you maybe speak to the challenges of the logistics of that 2,000 kilometers, and indeed how you're preparing for such a long trip?
Yeah, how long have you got? No, if I like in all seriousness, yeah. Yeah, so it's probably maybe more now actually, since because that 2000, since we came up with that 2,000-kilometer figure, we've probably rehashed the route slightly, so it might be nearer to three. But either way, it's a significant distance. It's a mixture of some roads will be tarmacked, some roads definitely won't be, and some of it will be completely off road. And we're quite lucky because we've got partners in Zambia. We have some local knowledge. It's not like we're going somewhere where we have absolutely no idea what it's going to be like. That being said, things change dynamically quite quickly. So yeah, logistically, so it's going to be a case of us having two land cruisers. So we've got redundancy, and then we have another, one vehicle breaks down. We've still got the other one. We'll make sure everyone has the relevant sort of driving training and off-road things. And we've got myself, and then Ben Lyon, who's obviously done loads with the military, who's going to be coming along. James Dyer, who you may know of, who's done a lot of expedition leading. So I think we've got a good skill set of people who are going to help us flourish. But the logistical side of things is it's not just the vehicles. Vehicle wise, it's fuel. Where are we going to be filling up? How much redundancy do we carry with us? Water, supplies, that sort of thing. I just got a delivery of lots of ration packs yesterday, so it's getting quite real. But there's so many different bits to think of, accommodation. Because at one point we're thinking wild camping, then actually went a bit further into our risk assessment, and we're like, that's probably not the most sensible thing to do in certain locations and things. So yeah, so many different challenges, and that's before we even start thinking about obviously the medical side of things, and evacuation planning and things like that, and med kits. But it's all good. It's all part of some of the stuff that I suppose we teach it on all the courses, don't we? It's just putting some of it into practice. And like we were saying before the podcast, I guess the challenge for me is normally if I'm joining an expedition or something like that, not all of it, but some of this is done. It gives you a real eye opener into the amount of like back end stuff, and even how something that seems quite simple, which it can be simple, still takes up a huge amount of time and brain power. So for me, actually, it's been a really good learning experience. And the reason I've assembled the team that I have with bits of different experience, so we've got. It should be nice to say who's in the team. So,
Yeah, no, indeed. Let's do that.
there's
Yeah.
me. There's Hugh Jones, who I mentioned, who was a safari guide in sort of a former life. He then founded the Virtual Doctors, now lives out in Bulgaria. There's James Dyer, who's basically a professional expedition leader, has done so many cool things. And there's James Ferry, who is the executive director of the Virtual Doctors. So he is Zambian. So it's nice that we also have a bit of a link back there as well. Ben Lyon, like I said, so just literally left the Royal Marines, now in the reserves, but obviously extensive experience there. Also does some work with WAM, so he's coming along as well, and then he's going to be leading the trauma training aspect of that, which we didn't touch on, but briefly is again, trauma is a significant thing that we get through our cases. We just want to sort of delve into that a bit more. We've also got Wilson Muba, he's our in-country lead for the Virtual Doctor, and this is why we want we want to make sure that actually it's not just all external people coming in and going on a jolly. We've actually got the people who do the things on the ground as well. Scott Johnson, like I said, so yeah, he's it doesn't need an introduction. He does all sorts of cool things. And then a chap called Jack Fisher, he's our videographer. So a lot resting on him. No, he's going to hopefully capture the expedition, but in a very kind of nice, organic way. We're not really going out saying, look, make sure you make a film about this. We want to just, see what happens and things. So that'll be really cool. And then our experts sort of in country is Marcel going to be doing the snakebite training. And then Alice Chun is going to be flying in to help with the solar lantern aspect of it for part of the trip as well. So a few different people. But the reason I was going through that team is that they help me in case I have any blind spots, whether that's, James Dara with the logistics side of things, Hugh and James looking at, they've spent, and Wilson as well, who lives in Lusaka. They're the experts for Zambia, when we've got Scott from the telemedicine aspect, Ben, who can, actually we're both developing med plans together so that, first off, if something happens to one of us, there's that redundancy, but also it means that I don't just assume that I've done everything correctly because there's someone else who can go through things, and having that team around you makes all of this, but it makes a difference because otherwise you can fall at the first hurdle, which you obviously don't want to do.
No, indeed. Like you said, just covering blind spots is absolutely key for resiliency. Just a couple more questions, Daniel, before we finish. One would be just endpoints from your perspective around evaluation of success of the initial expedition. Could you maybe speak to what endpoints you're looking to achieve to sort of deem it a success, and indeed, you've already spoken about proof of concept. And extrapolation to different countries, which I think is fantastic. Could you maybe speak to your definition of success and then how you can confer that to other countries?
Yeah, so I think that's a really good question. It's a hard one to answer, as this isn't me dodging the question at all. But the difficulty, and we've had this as an issue within sort of the standard day-to-day running of the virtual doctors and trying to get outcome data, is that it's really hard getting good outcome data. Partly because, I think it comes down to time management a lot of the time, and not the inability to manage time, but just the burden of patients coming in. So for the charity, we're always trying to get outcome data. What happened to that patient? So we gave a clinician some advice. Did it make any difference to that patient journey? It's really hard to actually get any follow-up and find out that sort of thing. So I suppose the reason I'm saying that is that the background is getting outcome data is quite difficult. But I think from the expeditions perspective, there's the main things we're looking at is the things that we can measure objectively are mainly going to be linked to the education. So the trauma training and the snakebite training. And this is why we want to make sure that we have that cascade ability so that we can look at how the training is, how it changes management. But then because we have our platform as well, we can then look at the quality of cases that we then get and be like, okay, these cases that are coming through are really good. They're managing XYZ really well. Actually, these cases, maybe they're not so good. And that proves that actually, there's obviously a huge amount of variables, but theoretically at least proves that the pilot that we did has done something. And similarly with the snakebite side of things. And like we were saying earlier, the ability to then have that data and present it either locally to district health officials or slightly higher up to the Ministry of Health then helps us both as obviously it helps patients, it helps develop local services, but it also helps us with the charity in terms of proving our worth as well. And then because we work alongside the Ministry of Health, but it's always difficult. You still have to justify your existence to an extent. But we're in a good place with those relationships. But we also, like I said before, we sort of want to work towards that exit plan and building up those relationships and showing that the technology, particularly now it's been redeveloped and can do more things, and showing that can work, but also that we can link it with in situ training that we've shown as a proof of concept works. We'll then upskill some people who can then deliver it in country. it shows that that whole sustainable package hopefully would then come together. So I think those outcomes are going to be easier to do. I think the outcomes like looking at accessibility, solar lighting, those kind of things, they're a bit more qualitative, I guess. One of the main things that we're hoping to get is just understanding the experiences that the clinical officers are facing and the challenges. And I'd hope that that will then enable us to, well, fine tune what we do to support them. But another thing as well is that it's good to have this information to be able to share with our volunteers in the UK and elsewhere. So for volunteer wise, they are mainly based in the UK as NHS doctors, but we are widening that to dentists, nurses, physios, still in the UK at the moment, but certainly up to allied healthcare professionals. And the plan is to get that for US, Australia, and other countries soon. There's just a few indemnity challenges that we have to clarify, but I think it comes back to what I was saying at the very start. Raising awareness of those global health issues through getting more people involved, and you can only really raise those awarenesses if you can understand and get that whole construct across of what it's actually like on the ground and things.
So just finally, as we come into land, Daniel, could you maybe speak to the future aspirations and goals beyond 2024? What does you've already spoken to, extrapolation of this expedition to potentially Malawi and other countries, which I think is fantastic. Could you maybe speak to sort of your vision of a future impact on healthcare in Zambia, but also beyond to wider Africa, really?
Yeah, so I think it's important to say that so this expedition is probably going to be a one-off in terms of the physical going on an expedition, because it's good, and like I said, there's loads of reasons why we're doing it, but it's also important to realize that you can achieve quite a lot of what we're doing without further expeditions after that. I mean, that this is going to hopefully establish some concepts, hopefully get some really good quality outputs, but also footage to raise awareness of what we're doing and things like that. But after that, once we've done that, and this is partly why we're front loading it through this year's expedition, I'd be hopeful that we can roll out, that cascade, that training, some of these other aspects without physically having to go there. Because it comes back to, if we look at the things we were saying about climate change, it's a bit hypocritical if we then fly out to Zambia every year, for example. So, yeah, I think it's important that this one is happening, but I think we can also achieve other bits without necessarily needing to be there, and that fits in quite nicely with what the virtual doctor's ethos is, because it's the ability to volunteer remotely, and so I think the longer term visions and the sort of extrapolating to other countries is that, we use this, like we've been saying, as that pilot proof of concept. And yes, there may be future expeditions. Like, of course, I'd love to have future expeditions, but so as the medical director, I'm also a trustee of the charity. We also just have to have our other hat on and think about, all the other bits that I just said, really. So yeah, I think, it may kind of develop into something in Malawi. But I'd be hopeful that we can do some of that without having to necessarily be there. I'd obviously love to be there, but
Listen, Daniel, that's fantastic. Listen, thank you for your time over the last hour, and it is a fantastic expedition with some, like you said, really insightful and sustainable endpoints. It's going to be really fantastic to hear your reflections on the back end as well of the expedition. We'll put links in the show notes so people can find out more and indeed hopefully donate and contribute towards the expedition. And just thank you for your time.
well, no, yeah, thanks very much. It's always good to catch up. And if people do want to hear how we get on, so myself and Ben Lyon will be speaking at the conference later in November. And you can find out all about what we've got up to. We may have a show reel by then. I don't think we'll have only just got back, so we won't be able to sort of show you our full output at least. But yeah, we're going to tell you all about how we got on.
That'd be fantastic. That'd be fantastic. Many thanks, Daniel.
Thank you.
Thanks for listening to the episode. Please feel free to rate, review, and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website, where you can find more engaging content on extreme medicine webinars and indeed the collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical, and performance medicine. Thanks again.